All right. I know that we are a couple minutes ahead of schedule, but I do just want to get started because we do have a lot of housekeeping items. I'm sure more people will join as we get closer to the hour. My name is Bridget Sweeney, and I'm the training coordinator for the Maryland Addiction Consultation Service. I'll go a little more into our services, but I do want to start off by saying thank you to BHIP, who is also partnered with us today. So I'll give an overview of their services as well. As you may have noticed, our registration process has changed. We now conduct registrations as well as evaluation surveys and certificate pulling directly through our learning management system called Max Oasis. I included those links in today's reminder email, but I will also send them in the follow-up so that you do have that on hand. That will be where you access the slides, once again, the evaluation survey, any other Max resources, and once you complete that survey and your attendance is verified, that's where you will access your certificate as well. Before we get started into content, I will give an overview of our services here at Max. So we are grant funded through the Maryland Department of Health Behavioral Health Administration. So all of our services are totally free to you as prescribers and members of the healthcare team. And those services include a clinical consultation line open from 9 a.m. to 5 p.m. Monday through Friday. We call it a warm line because you will not be immediately connected with a consultant, and we do not take emergency questions, but you will be directly connected with our behavioral health consultant who will collect more information about what you are looking for, those specific clinical questions you have, and then point you towards the appropriate consultant to answer those questions. So we are a great service to utilize, especially if you are becoming more comfortable with treating patients living with any type of substance use disorders. It's not something you feel totally comfortable with. You have concerns. This is a great service to tap into. And Dr. Fishman's a great example of a consultant you would be connected to, especially if you treat pediatric patients. We also offer education, including webinars like today. They're usually held during the lunch break to accommodate your busy schedules. Those didactic topics range from opioid use disorders, alcohol use disorders, motivational interviewing to get patients engaged in substance use disorder treatment. A really popular topic for us right now is pain management. We do have a pain management consultant who will be presenting a webinar in February, and I can follow up with more information about that event. If you are interested, please reach out to me via email. We offer technical assistance, which aims to increase your practice's ability to treat substance use disorders in a standardized way. So that can be anything from helping you write implementation protocols, helping your team get on the same page. It even can be setting up individual trainings for your practice about specific topics that all of you seem to be having patterns struggling with when treating patients living with substance use disorders. So that's another great service. We would connect you with our senior technical assistance representative who would help walk you through those projects and follow up to ensure that we are supporting you the best that we can. Another educational opportunity we offer are echo clinics. Those are held once a month, and they are a little more collaborative than didactic presentations. How they work is you or someone else from the medical community would come with a de-identified case from your own practice and present what you are struggling with that patient, walk through questions you have, and then receive feedback both from other members of the medical community as well as a panel of our expert consultants. Those case-based learning activities are then followed by a short didactic presentation. So once again, that's a really great way to get free credit. Those are offered once a month. We have 3 different rotations going right now. That includes one for just general substance use disorder, no matter what type of practice you work in, you come to that one and present your cases. We also have one specifically for individuals working in OTP settings. And then we have one for individuals who work in maternal healthcare settings. So those are just 3 rotations you can always sit in on. You are very encouraged to bring your own cases. It's a really great way to get real-time feedback about patients that you are seeing. So look out for those registration links in the chat as well. And I mentioned this a little bit with the Echo clinics, but we also offer Max for Moms. So those are all the services that we offer for Max, except they are specialized for maternal health providers in addressing the needs for their pregnant and postpartum patients with substance use disorders. So we do have expert consultants who specialize in OBGYN services. and that is another resource to take advantage of. We are holding a mom-specific half and half buprenorphine training around March, and I can put more information about that in the chat as well if that's something that you're interested in. And you can always reach out to me with questions about any of our services, and I'll include my email as well. As I mentioned at the beginning, we are partnering with BHIP, which stands for the Maryland Behavioral Health Integration in Pediatric Primary Care. So if our model sounds familiar to you, it's probably because you are more familiar with BHIP, and our model is based off of BHIP's model. So all of the services that we offer, they offer, but specifically, not just for substance use disorders, for pediatric patients' mental health concerns. So we will include their information in the chat as well. We are grateful to have them online with us today. We are grateful to partner with them for today's webinar. And Dr. Fishman does work for both of our programs. So once again, great consultant to tap into. Before I introduce our speaker, I am going to turn it over to our guest that I mentioned. So Kathleen works with the Office of Innovation, Research, and Development at the Maryland Department of Health, and just wants to remind everyone of their program in engaging the perinatal population in care. So Kathleen, I will turn it over to you. If you have I'm going to give you presenter privileges in case you have a PowerPoint you'd like to share. Once you're done, a couple minutes of talking, just turn it back over to me and I'm happy to introduce Dr. Fishman.
Sounds good. Thank you, Bridget. Let me pull up my presentation here. All right, great. And can you see my screen? Okay, great. So yeah, as Bridget mentioned, my name is Kathleen McGuire. I'm a policy analyst with Maryland Medicaid in the Office of Innovation, Research, and Development. And I'm here to share a little bit about the Medicaid Mom Program. So we're just going to take a couple minutes of your time. I know y'all are here for the BHIP presentation, but we've heard from many of the MACS team that several clinicians have expressed concern over a lack of programs to refer patients to for help outside of their own settings. And so Medicaid offers a program specifically for pregnant and postpartum individuals who have opioid use disorder. And we would love for your partnership in promoting and referring to the MOM program. So the MOM program funds our Medicaid managed care organizations to provide enhanced case management services to pregnant and postpartum Medicaid participants who have opioid use disorder. It's based broadly on 5 core case management pillars: comprehensive case management and care coordination, which is helping participants to make and keep doctor's appointments, health promotion such as HIV and STI prevention and treatment, nutrition, family planning, things like that. Individual and family supports, such as with the participant's permission, identifying and involving people who might serve as the support system throughout pregnancy, labor and delivery, and the postpartum period. And linkage to community supports, which is based on the participant's response to social determinants of health screening that the provider and case manager administer at intake. So what's different about the MOM program? MOM allows case managers to tailor their time based on the needs of the participant and rather than a set script. It starts with the social determinants of health screening, which informs the discussion of the individual's own goals. The idea is that, for example, the case manager won't just provide the participant with a WIC brochure, but they help them to set up an appointment and ensure that they have a way to get there. The same goes for doctor's appointments. The case manager aims to ensure that the person makes and keeps those appointments, whatever that may look like for that person, addressing issues of transportation, childcare, things like that. Participation in the program is also voluntary. It's at no cost to the participant. Their Medicaid benefits are not affected if they don't choose to join. Really, the program is just to support people who want to have a healthy pregnancy and a healthy baby while improving their overall well-being. This also doesn't mean that they need to stop using or that the program requires them to use MOUD, such as buprenorphine or methadone. We do encourage it, but it's not required. The MOM program will accept participants no matter where they're at in their journey. And we believe that the program can still benefit individuals who continue to use, such as by helping them to create a plan to use safely, encouraging attendance at prenatal and postpartum care appointments, and accessing community-based resources such as WIC and utilities assistance. We also welcome individuals who may not have used for years, as we know that pregnancy and postpartum can be challenging and pose risk for recurrence of use. And then as clinicians, you also have the added benefit of seeing the mom care plans and social determinants of health screenings, as those are available in CRISP. And we know that this is a challenging population to engage. Identifying, referring, and enrolling individuals for mom case management is an all hands on deck activity. And so we really need your help in this effort. We've created a communications toolkit that's available on our website, and I'll send out these slides to Bridget so that she can distribute them after the call. So we have a flyer that's available in English. We're working on a Spanish translation now, but that's just like a quick, one-page overview for participants who might be interested. We have social media graphics, advertisements, copy that's available in English and Spanish also coming soon. And we've also created a 30-second video that's available in English. And all of those resources are up on our website. The mom referrals ultimately do go through the MCO, but they can be communicated to the local health department or even directly to us. We have a direct inbox. We've also got a self-referral link that's included here. And then just to wrap up, this slide has our team's contact information and includes links to information for potential participants and for providers. It includes a link to our self-referral tool. It's included here. There's a link on the slide, and then it's also embedded into the graphic. And the electronic toolkit is available on the website. The flyer, we have a digital version and also a version that's been formatted so that you can print it out if you prefer. And, please don't hesitate to contact if you'd like access to these marketing materials or if you have any other questions about the program. And of course, we always encourage you to fill out the prenatal risk assessments, as that is where we receive most of our referrals. So thank you so much for Max to sharing their time with us, and thank you all for your attention.
Thanks so much, Kathleen. As Kathleen mentioned, I'll make sure that these slides are included in any of our follow-up as well as on the Max Oasis portal. Dr. Fishman, I'm just going to give a very brief introduction for you. I apologize that it's briefer than usual, but I do want to get started. Everyone should have noticed that your mic and camera are disabled. Please utilize the chat to enter questions throughout today's webinar, and we will try to get to them at the end. If for whatever reason we cannot get to them, we will follow up with you directly as a Max consultation. So please look out for any information about that. Dr. Fishman is an addiction psychiatrist, medical director of the Maryland Treatment Centers, and a member of the psychiatry faculty of the Johns Hopkins University School of Medicine. Dr. Fishman leads Maryland Treatment Centers, a regional behavioral healthcare provider, which includes Mountain Manor Treatment Centers in Baltimore and Emmitsburg, as well as several other inpatient and outpatient programs. We're grateful to have Dr. Fishman as a consultant for both MAX and BHIP. While you're watching today's presentation, try to think of those clinical questions specific to you and reach out to our warm line with those, and he's happy to help. Dr. Fishman, I'll turn it over to you to get started and take it away.
All right. Thank you, Bridget. Well, great to have everybody with us today and great to be here with you. We're going to talk today about young people, youth. That's both adolescents and young adults. So I combine that in the term youth, or as they say in Brooklyn, Utes. And it's not so much a bright line in terms of absolute age, but it's a developmental period of much change, both vulnerability and resilience. But today we'll be talking about that vulnerability and how it relates to substance use, just as it relates to other risk behaviors. Today's presentation will be a bit of a whirlwind, talking about a bunch of different topics. We could go on, all day, and I'd be with you here till midnight, but you don't want that. And so I'm going to talk about developmental vulnerability, talk about some epidemiology, who's using what's new, talk about cannabis, because that's on everybody's mind, talk a little bit about methods of engaging people in treatment and motivational approaches and language to talk to young people. talk about opiates a little bit, talk about family involvement a little bit, and that'll be more than we can fit in. So let's get going. First thing I wanted to do in introducing the topic is remind everybody about this very distinct and rich and special time in the lifespan, adolescence, young adulthood, and think about us, or at least me. I'm an old graybeard, an old fart. And so you look back on adolescents, and one of the things we do is we think of them as perhaps it is young people coming from a different planet or being so different from us. It's, for me, way in the rearview mirror. And we think about the things, the mischief they get into, the trouble, and we've got to be careful about that. There's a kernel of truth, of course. Young people, as I'll keep saying, have particular vulnerability and certainly are at higher risk than older people for substance use disorders and other risk behaviors. But we got to be careful not to be too preachy, not to widen the gulf in the generation gap, and not to be too preachy. The kind of, when I was a boy, people valued $1, and we used to walk uphill both ways in the snow barefoot. You got to be a little careful with that kind of stuff. But we do see them as having risk. And I thought this quote kind of embodies some of that perspective. I'll read it to you. We live in a decadent age. Young people no longer respect their parents. They are rude and impatient. They frequent taverns and have no self-respect. I mean, you can see that kind of snarky attitude, but it does encapsulate some of the things that we worry about in terms of youth and their immaturity and their vulnerability to risk. When do you think this is from? Just a quick guess. This has been going on a long time, right? Thoughts about that? Well, here, I'll let you know. Look, this is from a long time ago, and it just makes the point that this trend of the generation gap and our perspective as older people on younger people is not new. It's something from every generation, and we want to narrow the gulf and be able to reach out in a way that encourages people to accentuate resilience and mitigate vulnerability rather than just be old scolds. All right, so let's talk about developmental vulnerability. This is a look at the lifespan and rates of past month substance use for a variety of substances: alcohol, tobacco, binge alcohol, any illicit drug, and cannabis. And you can see that this scale is not linear, right? It's blown up on the left during the second decade of life and compressed on the right through the rest of the lifespan. And that's because on the left is where the action is, right? That's the ascending limb of the curve. We see that these behaviors typically have their onset in the early to middle part of the second decade of life and increase sharply to peak prevalence of substance use at the end of the second decade, beginning of the third decade of life. It's not that there aren't plenty of people over here on the right in the rest of the lifespan using substances, but when did they get started, right? We know that 90% plus of adults who have substance use disorders started before the age of 18. So it's critical for us to look at adolescent behaviors as an opportunity for altering the trajectory, intervening, doing not just prevention, but doing an intervention so that we can get to healing and not wait till the more progressed, more advanced, more malignant forms of the disorder later in the lifespan. Another look at developmental vulnerability is this data that shows risk stratification based on age of first onset. So this is asking adults whether or not they have problems with substance, defined here as having one or more dependent symptoms from DSM-4, so it's a little bit older data, based on their reported age of first use, not problem use, not regular use, but first initiation, first use for these three substances: tobacco, alcohol, and cannabis. And you can see in this narrow window from before age 14, first onset, to 15 to 17 to after 17, that there's an enormous stratification of risk, with between a 2-fold to an 8-fold increase in the risk of having persistent adult problems based on onset before 14 compared to onset after 17. It's just a 3-year window, but that's a lot of water under the bridge in terms of developmental maturation for a young person. And if you look across the top, onset before the age of 14 is roughly predictive of a 25%, 1 in 4 risk of problem status as an adult with any of these 3 substances. Now, I don't want to exaggerate, it's not 100%, but 25% is pretty high. So again, thinking about the vulnerability of adolescents as being different than the vulnerability of more mature older adults. Now, why is that? We could spend the whole time talking about maturation or immaturation of mind, body, spirit, and brain, but lots of what we know from emerging neuroscience tells us about some of the mechanisms inside the black box of developmental vulnerability. For sure, earlier onset predicts higher risk, and this has to do with immaturity, right? We know that brains are not fully baked and ready to come out of the oven till well into the second, third decade of life, right? Age 24, 25, 26. And if people have been using substances, that's even more delayed. And you can easily recount some of the qualities that lead to that vulnerability. Adolescents are more impulsive, have higher salience of excitement seeking. They have difficulty delaying gratification. Their executive function, which is the brakes and the inhibitory controls compared to the gas and the acceleration, are immature. And this little picture on the bottom right-hand corner is just one view of changes in the brain over the first 2 decades of life, as you see a particular increase in gray matter and decrease in white matter. And we won't go into the details of the neurobiology, but again, just one graphic manifestation of how rapidly changes are happening. And brain changes also happen as mind changes happen, as spirit changes happen, as bodily changes happen, as social changes happen, and all of those things are immature in adolescence, conferring vulnerability. All right, let's switch to looking at epidemiological trends in use. And this turns that on its upside down a little bit. This is non-use. So this is not who's using. This is the reciprocal, which is who's not using. And it shows a very interesting view. One of the things that makes this so relevant is that when you talk to young people about their use, they're often quite dismissive. Oh, it's no big deal. And we're going to come back to that a lot when we talk about motivational approaches, but it's no big deal. And everybody's doing it. I'm no different. Everybody's doing it. Why are you bothering me? Well, yes, a lot of people are doing it, but it's not exactly true that everybody's doing it. So for example, look at the cannabis line, and we'll come back to talking about cannabis more, but roughly looking at these 3 or 4 decades of history, cannabis with some blips here and there is relatively flat over the last decade or couple of decades, with 56% currently of 12th graders never having used cannabis in their lifetime, right? This is non-use for lifetime use for 12th graders. Now, that means if half of them haven't used, it means half of them have. So lots of people, lots of young people are using cannabis, but that's not everybody, right? If you look at the tobacco line, cigarettes, you can see illustrated the last few decades of one of the great public health victories of the last century, which is that we have an increasing trend of non-use of tobacco across the lifespan for sure, but especially in young people. And that's certainly a great improvement. Now, we have seen a little bit of a worsening in that trend in the last decade or so with the advent of vaping. There was a little bit of good news in this year's Monitoring the Future. There's a blip downwards. Whether that's a enduring trend or not, I don't know. Now look at the alcohol line, right? Non-use is increasing. And 40% of 12th graders have never used alcohol in their lifetime. 60% have, that's a lot, but it's not everybody. And then I think most illustrative and dramatic is look at the bottom all substances line. 30%, almost a third of 12th graders have never in their lifetime used any of these substances. No nicotine, no alcohol, no cannabis, no nothing. Again, That means 70% have. So yes, lots are, but it isn't everybody. So one of the things to remember when people say everybody's doing it is maybe everybody you know is doing it. And that's a cohort bias effect about the company that people keep with risk behaviors, but it isn't everybody. If you move to past month use, because this is lifetime, if you look to past month use, 12th graders have not used 51%, 50.9% of 12th graders have not used any substance in the past 30 days, including vaping. So these are encouraging trends, and you can see that the trend is upward. Something is going well. Smoking especially is not as cool as it used to be, so that's good. If only we could perhaps translate that into cannabis and not being cool, and we'll talk about that in a bit. But I think it's important to see that the trend is improving in terms of use and initiation. On the other hand, there is probably an increasing bifurcation, even as people are using less of a lot of substances. The trend is not towards less use in cannabis. Again, we'll talk about cannabis. And there is a bifurcation towards high severity use. So among those that are using, we are seeing a trend of increase among the smaller minority that are using a lot and having not just use, but use disorder and significant impairment. And we'll look at some of that data. This is illicit substances other than cannabis, and it tells the story of decreases in use even more dramatically. So whereas cannabis is flat, alcohol is relatively flat, other substances are trending downward quite impressively, but that doesn't mean that there's nobody in trouble. And as when we talk about opioids, we'll see that there's a minority group of opioid users among adolescents and young adults who are surely at the deeper end of the spectrum and surely in a bunch of trouble, with overdose trends increasing in just the last couple of years. One of the things that you want to understand in terms of historical trends and in terms of developmental vulnerability is the influence of culture, right? So all of you know that we are a culture that values and celebrates intoxication and equates it with the good life, with luxury, with leisure. And these are just some of the images that are the water that adolescents swim in. And it's very hard to counter message this. Listen to pop radio, watch movies, watch music videos, right? All of them are filled with the glorification of intoxication. And that is a very, very potent vulnerability for young people who see movie stars, pop music stars, etc., messaging this. The issue of perception is so important, and this data also reflects that. This is past month cannabis use. So remember, we saw lifetime cannabis use in 12th graders at about 50%. Past month use, more of an indicator of current use, is at about 20%. But the other thing to see is that graphed contemporaneously with perceived risk of harm. So that's asking young people, do you think cannabis is bad for you? Do you think cannabis is a problem? And if they say yes, they have positive perceived risk of harm. If they say no, that's negative perceived risk of harm. And you can see that these move in opposite directions as reciprocals. The more people think that cannabis is harmful, the less they use. The less they think it's harmful, the more they use. I can't tell you which comes first, chicken or egg, but they go together. And we are certainly moving into an era of decreased perception of harm with medicalization, recreationalization, say that 5 times fast, and legalization. And so expect that perception of harm will be going down as you see it, and then expect that use should be going up. There's a natural experiment across the country. I didn't vote for it, but you'll see that it's something we're going to have to contend with. And so not to forget alcohol, plain old vanilla alcohol, right, which is a significant problem in young people. It's a different pattern. Young people are binge drinkers, not so much the inveterate, chronic, high severity alcohol use disorder patients in midlife They're not drinking every day, morning drinking, withdrawal symptoms, a half a handle of vodka, but they are drinking on the weekends in binges. That we define a binge as 5 or more drinks per episode for a male, 4 or more for a female. That's a body weight adjustment. And adolescents are the segment of the lifespan that are highest across the lifespan in binge drinking. And you can see here for 12th, 10th, and 8th graders that those rates are alarmingly high. Just to talk about some of the other substances many of you will have heard about or seen, but just to review other things that are not as prevalent. Alcohol, of course, quite prevalent, and some of the specifics about youth targeted alcohol. They tend to drink a lot of beer, but they also drink a lot of hard seltzer and sweet drinks and pre-mixed cocktail cans. A brand named White Claws was one of the pioneers. There's now a zillion such brands. You may have heard the marketing slogans like "No laws when you're drinking claws." That's a pretty adolescent-friendly kind of slogan, and it seems to me like that's deliberate, targeted marketing, but they say no. Cannabis, you know all of the different names. You may or may not know, though, about the wax concentrates here, sometimes called dabs. You can see them held up as a wax concentrate, and there's a picture of a rock-like substance that you can shave up. That's, again, a wax concentrate of highly potent cannabis, and it's inhaled typically in a glass pipe. There's one in the right-hand corner, also can be a bigger apparatus. And in the middle here is a cannabis concentrated oil, which can be put into an e-cigarette device and vaped. Nicotine, one of the things that is the trend for adolescents is vaping as a first initiation of cannabis use mechanism, even before cigarettes. One of the trends we're learning is that although some adults use e-cigarette vapes as an alternative to cigarettes and even as a cigarette cessation or cutting down mechanism, for adolescents, they can be initiation as a path even before cigarettes and lead on to tobacco use. Important to know about the current trends in opioid use, which are often found in illicit, counterfeit pressed pills. So here you see counterfeit pills on the left. Those bluish ones are supposed to be Percocet, that's oxycodone, 30 milligram, or on the street, Perc 30s. And that's not pharmaceutical oxycodone, that's fentanyl pressed into pills to counterfeit the look of Percocet. And on the right is a counterfeit alprazolam or Xanax, but it's not alprazolam, it's not any benzo, it's fentanyl, again, pressed to look like Xanax. And that's particularly appealing. As you may remember from the days when prescription opioids were the primary route of entry for adolescents, the idea that they are somehow medically certified or a medicine that my grandmother might take for surgery detoxifies it a little bit. And so lots of young people do not know that they are using fentanyl. And fentanyl is now found in a variety of substances infiltrating the illicit supply, including to some extent cannabis, although I think that that's been over-exaggerated by the media. It is real. And then you may know about things like dextromethorphan, an over-the-counter cough suppressant, in Coricidin or Robitussin as some of the brand names. If you do use that in prescription strength, it's a good non-toxic, non-habit-forming cough suppressant without a lot of side effects. But if you swallow the whole bottle, you get a hallucinogenic effect, and that can be popular among young people as well. Focus for a second on cannabis. Here are just some current pictures that illustrate some of the trends. Up in the upper right, you see industrial scale growth in a big hothouse. That's becoming the rule across the country for either medical and or recreational sales now in most states. You see pictures of edibles. You see pictures of the size in big blunts, not in small, skinny reefers that maybe your grandfather or great-grandfather used. You see Snoop as an iconic messenger for popularization of cannabis. And as soon as the feds legalize it, he and Willie Nelson and Ziggy Marley are going to be marketing their big brands when the big boys and girls of Wall Street get a hold of it. So stay tuned for that. And then the graph on the bottom right is an indication of increase in THC concentrations in plant cannabis over a couple of decades, making the point that we've had 8 to 10-fold increases in the concentration. It's a different drug than it used to be. And so when parents say, oh, well, listen, we experimented when we were kids. We didn't inhale, of course, but when we were kids, we experimented and it was no big deal and we lived through it. Couple of things to say to that. One is, well, the next generation doesn't necessarily have to repeat your mistakes. Secondly, that it is not the same substance that it used to be. And these very high concentrations of both of plant cannabis and the extracts I was talking about before, and the amounts that young people are currently doing at the extremes in terms of daily use and multiple daily uses, make it an entirely different experience and vulnerability. Now, why do we care about cannabis? I think it's best to think about cannabis analogously to alcohol. It's essentially now legal, most of the country, and certainly all of the country within the next decade. And I think the feds will also liberalize restrictions eventually. And so it's not that it is a moral scourge any more than alcohol is. And most people who use cannabis, just as most people who use alcohol, across the lifespan among mature adults, use without loss of control, use without considerable impairment, use sporadically, can take it or leave it, use in small amounts, use without addiction, without use disorder. But vulnerable populations, and today we're talking about youth, both for alcohol and for cannabis, have markedly increased rates of escalation, progression to impairment and use disorder and loss of control because of their developmental vulnerability. So that's really the biggest thing we care about: progression to cannabis use disorders and increased vulnerability to progression to other substance use disorders beyond cannabis, and that clearly increases your risk. Other things we are concerned about are acute consequences of intoxication, like motor vehicle crashes. No, it's not as bad perhaps as alcohol intoxication. So driving buzzed may be less dangerous by a bit than driving drunk, but it seems to me there's more than two choices. What about driving sober? We're also concerned about the psychiatric consequences of use. And so the data shows us that, contrary to what some people, young people and other users will tell you, that ongoing use of cannabis worsens depression and anxiety, not improves it. There's a very clear link to causality of new onset and worsening of psychosis. And there's emerging information that still bears further replication about long-term use leading to enduring cognitive impairment. And we don't have time to look at all that data, but I encourage you to look into it. I think the evidence is very clear. Now, future harm is not necessarily going to be the way that we're going to dissuade young people, just as telling them that they may get lung cancer in 30 years is not going to dissuade them from smoking cigarettes. But you guys should know it, and public policies should know it, and public policy makers should know it, and family members should know it, that the evidence is very clear that the harms of cannabis for young people are very large. Again, not for all of them, for a minority of them, but compared to older adults, considerably larger. Just some data about progression to use disorder. This looks at what is the relationship between time from first initiation to development of a use disorder with impairment for cannabis and alcohol for adolescents and young adults. So you see that we're going from initiation within the past 12 months, initiation from 1 year to 2 years, initiation from 2 years to 3 years, initiation from 3 years or more ago, charted against percentage of having met the threshold of impairment with a use disorder. And one of the things you can see is that the rates of use disorder among adolescents and young adults are high. Not everybody, but high, and increases rapidly relatively soon after initiation. So within 1 year of initiation, first puff of cannabis, 11% of adolescents have developed a use disorder, right? And by 3 years, it's up at 20%. So it's rapid, and it's a impressively large number. Similar results for young adults, although they are more mature and have somewhat less vulnerability. But I think the key takeaway here is that it is a non-trivial number of people among young people that develop problems, and they develop them relatively rapidly after initiation. Now, there are people who will certainly be apologists for sporadic experimental use of cannabis among young people. Young people get into mischief, young people try stuff, try risk behaviors, they drive or are passengers in cars without a seatbelt, they have sex without condoms, they do a variety of things. Teenagers will be teenagers. And to a point, that's true. Even among most adolescents, don't develop use disorder, but a worrisome minority do. But I hope even those people who are apologists for that kind of normative risk-taking behavior with sporadic use, I hope that they wouldn't say that daily use is no problem. And here's some data about daily use. This is percentage of youth with daily cannabis use, 12th grade, 10th grade, and 8th grade. And this is somewhat older data, but the trend continues. 6% of 12th graders are daily cannabis users. That's a lot. Remember what I said about the bifurcation. We said that 50% have lifetime use, 20% have past month use, but 6% have daily use. That's a outlier. It's a minority, but it's a, to me, alarming minority. And if you look at 8th graders, glass half full, glass half empty, the good news is only 1% of 8th graders are daily cannabis users. The bad news is 1% of 8th graders are daily cannabis users. So it is a considerable minority that we need to think seriously about in terms of significant impairment. And here is just a quick survey from an Australian group that's been doing very good work in cannabis risk behaviors, looking at some of the correlates of daily cannabis use for adolescents. And just 4 of the notable things that they found, there is OR stands for odds ratio. That's the increased risk. So an 18-fold increase among daily adolescent cannabis users in persistence of cannabis dependence into adulthood. That's not so surprising. Past behavior predicts future behavior, but still 18-fold, very high. 3-fold increase in rates of high school dropout, 8-fold increase of progression to other substances beyond cannabis, and 7-fold increase in suicide attempts. Those would be mostly non-fatal suicide attempts, but still a marker of considerable mood dysregulation and risk behavior. So there's our kind of quick intro to cannabis. Let's talk about evaluation and treatment. Most of you will be familiar with the SBIRT paradigm. SBIRT is screening, brief intervention, and referral to treatment. The idea of staging interventions according to severity, a thing that non-specialists can do very easily, whether it's in primary care medical settings, whether it's in behavioral health counseling settings, whether it's in school settings or school counseling or school wellness settings, any place where adolescents are. You can do this very briefly, very quickly, especially on the earlier end. So this means For those that are not using, give them encouragement and cheerleading and positive reinforcement. For those that have just done some normative experimentation but have not progressed to frequent use or problem use or meet criteria for an SUD, give them brief advice about why it might be a good idea to reverse that trajectory and why they should not progress, and to encourage them and think about pros and cons with them. Where most of the heavy lifting will happen in non-specialty settings is in this third bullet, brief motivational interventions for those with mild SUD. So kids that are using have begun to develop some problems. They may not see it that way. How do you briefly try to connect with them in a motivational way to try to change the trajectory? And then lastly, for those that are beyond that level of severity that can be managed in non-specialty settings, doing a referral to local resources for specialty treatment. The key is not to expect immediate behavior change and the epiphany of the scales falling from a young person's eyes to change, right? Kids are primarily not seeing the harms of substances when they present to us. It's that some grumpy adult has brought them to our attention, or we have done a screening or assessment and are worried about them. And typically they don't buy it at first. These are the standard Prochaska and DiClemente stages of change you guys are all familiar with. But the thing that I want to emphasize is that when we see young people typically with substance use disorders, perhaps the exception being high severity opioid use disorder, where they know they're in trouble, but most of them are going to present in pre-contemplation, even pre-contemplation. So they don't think they have a problem, and we shouldn't expect them to jump to action and behavior change quickly. We're going to be spending most of our time here doing motivational enhancement, building therapeutic alliance and relationship to try to get them to contemplate what it might be to change behavior. And it's a marathon, not a sprint. So you got to have that mindset going into it that you're playing the long game. This is not helpful, right? This old style approach of trying to scare people straight and tell them about all the evils. These are some funny old cartoons about cannabis. Maybe some of you have seen that old black and white movies from the 20s and 30s, Reefer Madness. If you haven't, you can look on YouTube. It's a hoot to see some of the old propaganda. But you want to establish credibility contrary to old historical exaggerations. Listen, the truth is trouble and it's bad enough. You don't have to make stuff up. And be able to connect with young people in a motivational way, meeting them where they are, to try to engage them about their own lives in realistic ways. So let's spend a few minutes talking about some approaches and some language that can be helpful. Everybody's got to find their own voice. You talk to the kid in front of you in the way that you get to know that particular kid and in language that you think as you get to know them will be helpful. But just to give you some approaches that have been helpful in my hands and some language that I use. You can't go up the middle, right? You can't be fighting and battling and lecturing. That's likely to push kids away and produce resistance. You want to do the end around thing. And so I typically start the conversation, do you think you're having trouble with your substance use? And they say, nah, it's fine. I don't use any. I'm just like everybody else. I'm not in trouble. I can handle it. I'm not using any more than anybody else. Everybody's doing it. I don't know why you're bothering me. All right. So maybe we'll agree to disagree. I use that term a fair bit. That's fine. I appreciate your being willing to talk to me about it. Well, let's talk about other people you know. You know anybody who's got trouble with smoking too much weed? And what I'm doing there is diverting from a personal kind of reflection, which they're not ready for, and obviating the need for them to be defensive. Everybody knows somebody, a cousin, a brother, an older brother of a friend, some other kid at school who's been in trouble. Do you know anybody else who's been in trouble? Why? Why is it too much? How can you tell that they're having problems? And where that gets us, maybe not on the same page, but maybe we're at least in the same book, that there is such a thing as too much cannabis. And we can start to have an honest discourse about how that's defined and how you can tell and what it would mean. Why does that person have trouble? Do you know why I or your parents or your coach or your girlfriend or your school counselor, why do they think it's a problem? You don't have to agree with us. We're full of baloney. I get it. But why would we even say the things we have? And that's an exercise in getting them to walk in somebody else's shoes. That's an important developmental milestone for an adolescent. And to articulate why we're concerned about their health, even if they don't agree with it, at least to be able to understand our rationale. Talk about the pros and cons, always lead with the pros. People wouldn't use substances if they didn't like them. So you gain credibility by acknowledging the upside. All right, now what's the con side? What's the downside? Oh, there's nothing wrong with it. Well, all right. You say it's no problem now. Let's say that it did become a problem. Let's say it did progress. Let's say in some alternate strand of the multiverse, there was a scenario in which it could be a problem for you. What would that look like? What's the line that you are not crossing that means it's not a problem? And what line would you have to cross in your imagination that it would be a problem? Let's explore that together. You say, what, you only smoke on the weekends? Would it be if you started smoking on the weekdays? You only smoke with other friends. Would it be a problem if you smoked alone? You only smoke after school, after your homework's done. Would it be a problem if you smoked at school or before school? You see where I'm going? So is there some line? And that now personalizes the hypothetical conversation, that not only is there such a thing as too much, but that there might be a personal limit for you. And what is very helpful about that, right, is then that becomes fuel for a future conversation when they come back and you look at your notes and you say, you told me that you were only smoking after school and that it would be a problem if you smoked before school, but now you tell me you smoked last Wednesday before school. What do you think about that? I've changed my mind, Dr. Fishman. It's fine. All right. But in a series of those conversations, we can hold up the mirror of that person's own personal story, not some textbook, and talk about a series of progressions and lines crossed. And for some young people, they can see how that has changed over time as crossing a series of lines that you said you'd never cross, might be the evolution of developing a problem. Well, you say you could stop any time, but you haven't. Well, that's because I don't want to. All right, but you could try to cut down or quit, and it's not going anywhere. You can always come back to it, but who knows? What would it be like smoking less or stopping for a couple of weeks and coming back and let me know what it's like? And they could come back 2 weeks later and say it was horrible, or they could come back and say it was better. Mostly they'll come back and they'll say, oh, I forgot. Or no, I decided it was stupid. You're even dumber than I thought you were. Of course, I'm not going to stop. And you can say to that, I wonder if it's tougher for you than you thought it might be. And maybe it's got its hooks into you more than you thought. And that can be motivating to some people. But the most important thing is to have these conversations and to set the stage and do the role induction for a open and hopefully honest interchange. Thanks for talking about these difficult things. Thanks for telling me what you really believe, because I don't want them to say, okay, Dr. Fishman, I'll never smoke cannabis again. You're right. Because that's not helpful and it's not true. I want them to push back. I want them to tell me that they disagree or don't disagree and what they disagree about, so I can get to know them and begin to interact and then set the stage. Will you come back and can we continue the conversation, remembering it's a marathon, not a sprint, and motivational enhancement with progression across the stages of change takes time, and engagement is where you start. Here's some other digestible messaging. And I'm going to skip this one because we're running out of time, and I want to make sure to get to talk about opiates for just a few minutes. So opiates are nowhere near as common among adolescents and young adults as alcohol and cannabis, but they're obviously so important because in that small minority who are using, they are so deadly. And we've been talking for several decades about overdose deaths across the lifespan, and we've ignominiously crossed the threshold of more than 100,000 overdose deaths a year, and certainly not proud of that. But it has not been as bad among adolescents and young adults. But in just the last couple of years, even though the numbers are relatively smaller among adolescents and young adults compared to older adults, we've seen an alarming uptick in adolescent and young adult overdose deaths. And that's reflected here. And here's another look at adolescents over the past 5 years. Again, the absolute numbers are small, but the trend is up. And it made a bit of a splash. You may have heard of this rag, the New England Journal of Medicine. There was a nice editorial just this month talking about the overdose crisis in U.S. adolescents. So I'm glad it's getting some attention. And what do we do about it? We could, again, spend all day talking about this, but I think the most important thing to do is first frame the issue broadly connected to other adolescent SUD. That is, opioid addiction doesn't happen in a vacuum, right? People don't just catch fentanyl use out of nowhere. We think of addiction broadly as a developmental disorder of pediatric onset. That's a nice tagline for what we looked at the beginning in terms of developmental vulnerability. But it's important to know that the vast majority of adolescents who do initiate opioid use were previously in trouble with loss of control of other pre-opioid substances. And for adolescents, what is that? That's cannabis, alcohol, nicotine, right? So it is a continuum of the arc of the broader illness of SUD, then progressing to a more malignant, advanced, accelerated stage, but with its roots in the less severe forms of the disorder. So there's a message for prevention, which is in order to prevent opioid addiction, in order to prevent opioid overdose deaths, we've got to intervene upstream earlier before kids get to opioids when they are already having problems with other substances. Now, once they have opioid addiction, that's not enough. It's too late to prevent. So treatment is paramount. And the take-home message here is that the same tools that we have a very strong evidence base for across the lifespan in older adults apply to adolescents and young adults. That is the standard repertoire of medications for opioid use disorder. And the 3 FDA-approved medicines, buprenorphine, methadone, and extended-release naltrexone are the ones to use. Methadone less so because of the specialized settings where regulatory limitations focus methadone use are generally not adolescent-friendly programs, but both buprenorphine and extended-release naltrexone, and now extended-release buprenorphine, can be used in any medical setting. And the evidence, although not as strong as for older adults, just because not as much research has been done, but what evidence there is, and there's a fair bit of it, and the strong and increasing expert consensus is that buprenorphine and extended-release naltrexone are effective for adolescents. And although the outcomes are not as good as for older adults, less adherence, less non-relapse, the same developmental vulnerability that has them getting into trouble at higher rates, has them responding perhaps at lower rates, but they work. They save lives, they prevent overdose and overdose death, and they alter the course and trajectory of opioid addiction, and they are safe. All medicines have side effects, but there are no additional side effects conferred by chronological age. They should be the standard of care. There's no reason to think of them as having age limitations. There's no reason to think of them as having a fail first initiation basis. That is, you've heard some people perhaps say, oh, what about giving a young person a trial with non-medication treatment first, and then if that doesn't work? No evidence for that. People do not do as well without medicines. Also, what does fail first for opioid addiction look like? That could be a fatal overdose. That's not worth the risk. And then just a word about family engagement, and then we'll take some questions and discussion. I won't go through these slides, but just to make the point that, and I think this is true across the lifespan, but it's especially true for young people, that families are an underutilized source of motivation and promotion of recovery and healing, and can help with initiation of treatment and help with persistence of treatment. And we just haven't been good enough about including families. And the reasons include worries about training, concerns about competence, concerns about confidentiality. And those are all understandable barriers that need to be addressed. But the juice is definitely worth the squeeze. When you can get families educated about the problems, whether it's opioid addiction or pre-opioid addiction with cannabis and alcohol, and get them involved and give them information and coaching about how to be more consistent and persistent in their parenting approaches, tailored at treatment success, you can do very well. And surprisingly, most young people, including young adults over the age of 18, will accept it gratefully. They may at first say, you can't talk to my mom, you can't rat on me, but getting to yes is always easier than you might think. And we're near the top of the hour, so I'm going to stop with slides and pause for questions. Bridget, if you will help me read from the chat, or if people will unmute themselves and ask, that would be fine. And I'm willing to stay longer. I don't want to keep people, so anybody who needs to go, go, but let's have some discussion and some questions.
Thank you so much, Dr. Fishman. This is being recorded. Question and answer will be recorded. So once again, if you do have to log off, please feel free. Right
And
now,
yes, you can have the slides.
thank you. The only question I'm seeing right now is, why do you feel as though cannabis is so popular among adolescents? I know you addressed it a little bit in the talk, but if you could just answer that again. Thank you.
Sure. Well, one reason is it has become so normalized. And again, think of the analogy to alcohol. Alcohol is condoned, ritualized, and supported in this country across every manner of social interaction. It's even ritualized by some religious practices. It's been around for 10,000 years, since people first left out a fruit mash accidentally, and it got fermented by wild type yeast. And adults are doing it and normalize it and celebrate it. It's hard to keep it out of their hands. The same is now increasingly true for cannabis. It's a medicine, it's safe, it's legal, everybody's doing it. My family is doing it, Snoop is doing it. Why wouldn't you? The perceptions of harm are drastically reduced. I think it's important to start with the conceptualization that intoxication writ large is fun for most people. And we are hardwired as mammals to be reinforced by intoxication experiences. Think of 2-year-olds, 3-year-olds who spin around to get dizzy. It's universal. The question is, most people don't progress, right? Most people don't lose control and develop disorder, but adolescents are more vulnerable. And the question is, what can we do to do primary prevention to reduce initiation for the whole swath of young people who are vulnerable? But then also, how do we do targeted prevention and intervention for those that are at particularly high risk? And we know something about how to identify those people. Again, we don't have time to talk about it a lot, but other vulnerability, like emotion regulation vulnerability, that you can identify in infancy and toddlerhood, or concurrent psychiatric comorbidity and the like, are also, ways of doing targeted prevention.
Thanks so much, Dr. Fishman. The next question I'm seeing is, any thoughts about looking at video gaming through a similar lens?
Sure, lots of people talk about that. That the ultra rapid and high amplitude reinforcement that the geniuses who write these video game scripts and graphics plug into are very compelling to young people. And certainly it's a normative behavior for a lot of young people, and their parents may complain that they spend too much time, but they still don't lose control, still do their homework, still play sports, still, have relatively normal lives. But a subgroup gets swallowed up in the game universe, and their scope of life narrows so that all else fades away. Whether you call that addiction or not is an argument about terminology, but much of the phenomenon behavior is similar. And those kids at that high end of the spectrum do get impaired. And there isn't a very advanced knowledge about efficacy of treatment interventions, but it's certainly an area that people are very excited about. And, well, excited, that's the wrong word, but interested in, because it's certainly great need. Reciprocally, there are people who are interested in using those kinds of tools therapeutically, because as long as kids are reinforced by it, what about delivering substance use and other risk behavior interventions in a way that can be compelling? But, that's another story. And so far, nobody has been super successful at it, but people are interested in it, and I think it has merit.
Awesome. We have one last question in the chat, and then I will say if you do put any other questions in, we will turn them into Max consultation calls and follow up with you directly.
Sure.
But this last question is, if you get an adolescent to admit there may be a substance use disorder, what do you do next?
Well, first of all, I'd say it's a huge achievement. And so celebrate that you've got progress in the conversation. And if you can get that young person to start to reflect, then you can start to talk about, well, what motivates you to change, and how important is it to you to change, and how likely is it that you might change? And there's a tool called a readiness ruler that helps display that in a graphic form. And sometimes that's helpful. But the idea is, what do you want to do about it? What are the most important concerns that you have? What would you think would be relevant goals? Do you want to cut down? Do you want to quit? Do you want to limit the context of your use? Do you want to set boundaries? Do you want to monitor it? Are you interested in input from me about some suggestions I might make? Who else can we get to help you with this? Do your parents know? Well, I don't want them to know I'll get in trouble. Well, what if we rehearsed and did a role play about how you might talk to them? Because I bet you're wrong. If you came forward with this, I would think they'd be very proud and very eager, not to get you into trouble, but to help you and support you. What do you think about that? Would it be better if I told them, if you told them, if we told them together? Who else could help you? Do you have a teacher? Do you have a counselor? Are you interested in counseling? What about your pediatrician? What about your boyfriend, girlfriend, coach, minister? Who are the adults in your life that you think could be of assistance to you? But you hear where I'm going is, what could next steps be? And then what are you willing to try? And then can we come back and debrief on those next steps and talk about next steps and next steps and next steps? Again, back to the marathon approach to keeping at it over the long game.
Thank you so much, Dr. Fishman. No other questions, just a couple statements just reiterating what you've said throughout today's training. So thank you all for sticking online with us, especially for these extra couple of minutes. Please look out for follow-up emails, including the slides and information about accessing the evaluation survey. Please join me in thanking Dr. Fishman. It was a great webinar as always. And please keep him and Max and BHIP in mind as a resource. Definitely tap into all of us. We're happy to help with any clinical questions or any questions you have about substance use disorders. Enjoy the rest of your afternoons, and please do not hesitate to reach out to me with questions. Thanks all.
And the same with me. You guys have my contact info. I'll send the slides and we can send them out. And I'm happy to have your emails and calls with other questions or clinical cases.
Thank you so much, Dr. Fishman.
See you, everyone.